Good morning, everyone. Welcome to Families Together in New York State's third 2025 Town Hall. Today's Town Hall is on mental health and addiction recovery. I'm Paige Pierce. I'm the CEO at Families Together. We've been holding these town halls since 2021, and we have been we've included them along with our Family Empowerment Day because this is a real opportunity where commissioners and legislators of that chair the committees have some real time to talk with our families and young people. We have hundreds of people who sign up and listen, and then many more who watch the recordings on our YouTube channel. So welcome to everyone. Today's Town Hall, Mental Health and Addiction Recovery. We're very fortunate to have with us the commissioners from OASAS and from OMH, as well as our chair of Mental Health Committee in the Assembly, Assemblywoman Simon. And we'll have joining with us in a little while, Senator Brouk, who's the chair in the Senate of the Mental Health Committee. So I'd like to just introduce each of the commissioners and give them an opportunity to introduce themselves and talk about their agency and just a couple of minutes of what they're up to that would be relevant to our families and young people. And then we're going to let the ambassadors, the young people and families, ask their questions. So Commissioner Cunningham, do you want to go first?
Thank you so much. So I'm Dr. Chinazo Cunningham, the Commissioner of OASAS, the Office of Addiction Services and Supports. And thank you for inviting me to be part of this panel. And thank you for just bringing us together for this forum. So just as a reminder, at OASAS, we really are one of the nation's largest substance use disorder system of care. And so that means that we oversee about 1,700 programs that include prevention, treatment, harm reduction, and recovery. We serve over 730,000 individuals, and then we operate 12 state-run addiction treatment centers. And so we also oversee the credentialing of all of the professionals, including counselors and prevention practitioners in New York State. So I think many people know about the overdose epidemic that we've experienced in the last several years, which was really the worst epidemic ever in the history of the state and in the country. And at the worst of that, which was in 2023, over 6,300 New Yorkers died. That was one New Yorker dying every 90 minutes. But the very, very good news is that things are really improving. And so in the last 12 months, we've seen a reduction of 32% of overdose death rates. And so we're very, very optimistic about that. And so that's over 1,000 people who would have otherwise died of an overdose who haven't. And there's a lot of efforts that we've put into making that a reality. And I'm also proud to say that we're outpacing the nation in terms of this reduction in overdose deaths. And a lot of that comes from our harm reduction efforts, including distributing over 350,000 naloxone kits, and then also fentanyl test strips and xylazine test strips. So we're proud of that work, but of course we still have a lot more work to do. It's still too many people are still dying. And so this is really important that we continue to do this work and really continue to work together to make that happen. So we do that by really following our guiding principles, which include, using a harm reduction approach, a data-driven approach, and an equity lens in everything we do. So I'm just going to quickly sort of go through some of the highlights of the things that I think are most important for everyone here in terms of families, in terms of what we're doing in our continuum of care. So in terms of prevention, we do a lot of work in schools and community-based education programs. We have a youth leadership initiative and peer support initiative, and really a lot of programming that builds resilience and coping skills for young people and families and parents. In terms of treatment, we have designated outpatient clinics for adolescents and young adults, and so really having that expertise for that population. We also have residential treatment programs that are tailored for young people, young adults and youth. We have, medication treatment for opioid use disorder in which young people are eligible, and then a lot of work to integrate our mental health and substance use disorder services between OMH and OASAS. That really, I think, is important and continues to grow. In terms of recovery, we have youth clubhouses that we are planning to continue to expand, and then certainly work with our youth peer advocates. In terms of family supports, we have family support navigators that we fund, and then, you know, parent and caregiver education and support groups, and then counseling and treatment options for impacted family members. So I think, you know, that's just sort of a highlight of going through our continuum of care, and then happy to again engage in this discussion and these questions. And again, I just want to thank you for inviting me and my agency to be part of this discussion.
Thank you, Commissioner. Commissioner Sullivan from the Office of Mental Health.
Hi, good morning, everyone. And again, just as Commissioner Cunningham said, thank you so much for having me here today. It's a real pleasure to meet with you all. Just to give a brief update on where we are, I think the Office of Mental Health serves almost 800,000 people a year in terms of services across the spectrum of services. We still have our hospitals, 23 hospitals, and we have several still hospitals for youth as well. It's a very comprehensive system of care. But I'd like to give just a couple of highlights of what we're doing. And the first is to thank you for your partnership, Families Together, in our Youth Mental Health Advisory Board, which is going really well. And that Youth Mental Health Advisory Board has actually helped us to design one of the new programs that we're pushing out, which is safe spaces for our young people. And they've been very, very vocal about what that should look like and how we should do it. And I think as we send out those RFPs and stuff, I think the Youth Mental Health Advisory Board will see that. We'll see their input in real life coming forward. And similarly on other projects as well. And similarly the Family Advisory Board as well. Thank you so much for helping us with that. It's been really very, very helpful as we design some of these new services. The 3 years since Governor Hochul has been investing tremendously in mental health. Just to give you a few highlights over that first $1 billion budget that then went another year for almost another 600 million and another. So we're talking about an increase overall of over $3 to $4 billion in mental health services across the state. And a few key highlights of what we're seeing. First of all, a lot of school-based work, a lot of school-based clinics, and we're doing much of the work there we're doing in conjunction with OASAS. We're coming together to do some programming, which will be jointly in terms of integrating the school-based clinics. We have over 1,200 now across the state, and we're going to continue to grow those. We've done a lot of teen mental health first aid, which is teens helping teens, and we're continuing to grow that across the state in the schools and the teens. So far, we've had very good responses to that. In terms of treatment, we've had, and we also have something called Healthy Steps for families, young families, in pediatricians' offices, and that's been expanding over these 3 years. So we're covering now about 300,000 youth and families across the state, and in the Medicaid program, where there's a mental health professional sitting in a pediatrician's office for anybody who needs help. You don't have to have a diagnosis, just to help families under stress. And we know there's a lot of stress right now in families that are dealing with issues, and that's spreading across the medical side. So there's a lot of prevention going on, a lot of suicide prevention also throughout the schools and our communities. And then access to care. We've been growing the certified community behavioral health centers, and they have a lot of youth. They have to have lifespan services. So they do a lot of services for youth and families. We've expanded from 13 in the state to 39. And the access so far that we're getting a lot of good feedback about those clinics really providing comprehensive services when families come in. They also have a lot of peer involvement. And similarly, so our crisis stabilization centers, which are jointly between us and OASAS, a lot of peer involvement, a lot of family advocate involvement in the crisis stabilization centers, which are coming up a little more slowly, but they are beginning to appear all across the state, and we will eventually have them up and running in the near future. So the crisis stabilization center is 988, the crisis hotline. I know that we're continuing to expand and invest in, and trying to make sure that the quality of that is what we need. And then lastly, some very intensive services that we are working very closely with all of you in planning. One is our home-based crisis intervention services, which have really helped a lot of families when they need something very intense and very focused on a crisis which is happening. When that's fully operational, it will serve 3,000 individuals at one point in time. So we're growing that. It's almost 2,000 now slots that we have, but that's continuing to grow across the state. We also started Youth Act, which has been very, we're getting very good feedback on Youth Act from both the providers and from the families who've been involved in Youth Act. I've had like a very high satisfaction response for Youth Act. And we think it's having an impact on families that really need that kind of intensive work. I think we're almost at 800 youth who've gone through Youth Act now. So this is growing and growing and will continue to grow. And we're doing outcome measures on all these new services. And so far as they've been growing, we've been getting some really kind of positive results. And then the last intensive one is some teams called critical time intervention teams that will wrap the services around individuals leaving the emergency rooms and the inpatient services. And those are connected to, and this is coming up a little more slowly because of placing beds is always hard, to transitional beds. Now that work is really going to, I hope, be able to have an influence both for youth and for adults in terms of making sure that we do the right thing when someone comes to an emergency room and the right thing when someone, if you need a hospitalization, when you are there, but also when you leave. We have updated all the regulations and we have teams working with hospitals across the state. This has been an issue for quite a while in terms of ensuring that discharge, ensure that when someone leaves a crisis service like an inpatient unit or an emergency room, that they are connected to what they really need for services. And that's going to take a little while to change some of the culture that hasn't been as good at doing that, but it is happening, and we've instituted all kinds of work with the hospitals, which is going to grow over the next few years. So there's a lot that's happening, a lot of housing for adults, 3,500 new units of housing that are coming up, separate from the usual ESHI grants, the Empire State Development that come out, 3,500 just for mental health that are in that first budget, which are now being developed and coming forward. That's a tremendous increase in housing. We have over probably now about 52,000 units of supportive housing across New York State, which is tremendous because we all know that if you're not in a safe place to live, everything else we do isn't as helpful. So all that work is continuing to grow, and we're continuing to grow these services across the state. And we're doing a lot of work also with our unsheltered homeless across the state between New York City and upstate. We have kind of successfully housed some people who've been living unsheltered on the streets or sometimes under, on somebody's corner or living on a park bench. The ones that are most challenging to work with, we have now successfully housed over 1,400 individuals across the state between New York City and upstate. So we're very, and they're staying in housing and changing their lives. So that's very exciting too. So there's a lot of things that are happening. I'll stop there, but just for people to know, and glad for questions. I know that we also have to get better at certain things. So I think your input and your helpful suggestions and your criticisms are always welcome in terms of letting us know how we can do things better. So thanks so much, Paige.
Thanks, Commissioner. And that's why we're here, is to share with you our ideas and our suggestions. As you know, our motto at Families Together is nothing about us without us. And so these are the us, and that we're here to share with legislators and commissioners our experiences and our questions, and we're really pleased that you're here to answer them. Assemblymember Simon is the chair of the Assembly Mental Health Committee. Assemblywoman, do you want to introduce yourself?
Sure, thank you. I appreciate the comments by the commissioners. I really appreciate your having this town hall. The issues affecting families and young people, I think the big challenge is very often in government, we have slots and we end up with siloing things, and we end up having programs for adults and programs for young people, but we don't necessarily connect those dots with the families who are also experiencing a great deal of pain when a family member has mental health challenges. So I'm new to this role, so there's a lot I don't know, as both commissioners will tell you. And I'm learning about the various programs in the state. I think one of the things that we are going to be dealing with this year is a real staffing challenges. Other people have mentioned that. I think you've mentioned it as well in some of your questions. And that is that it's getting harder and harder to have enough staff members who are appropriately qualified. And how can we bring people into the field? How can we keep them in the field? How can we provide the sufficient resources as well as the funding for those resources? So that's going to be a challenge. It's always a challenge. I think it'll be a more acute challenge this year as we face some federal budget cuts. So that's something that's like not a happy place, but we're going to try and make it as happy a place as we can and find creative ways to address those issues as we go forward this year. You know, the legislature comes back in January for legislative session. And the first thing we do, of course, is start dealing with the budget right away. And so I know that I'll be seeing many more of you as you advocate for programs and for funding for those programs. So I'm looking forward to working with you all. Thank you so much for helping to educate me. And I'm looking forward to your comments and your questions so that I can learn as much as I can as quickly as I can. Thank you.
Thank you so much. And I just want to say before I introduce Kadisha that all three of you hit upon some things. As I said earlier, there are many, many family members and young people watching this right now, and many more who will be watching the recording over the next months or so. And it's refreshing to hear you guys saying some of the things that we've been saying to you for many, many years. Stuff about peer support, about Commissioner Cunningham, about harm reduction, and the many of the people that you talked about that were lost in the epidemic were in the opioid epidemic were young people, and family members have been wringing our hands and not knowing where to turn, where's the support, and how do we help prevent. So the prevention stuff and the harm reduction stuff, we're really thrilled to hear you talk about. Assembly member, from hearing from us many times about the shortage of staff, not only the shortage, but the ability to attract and retain strong staff does require resources. And so we're always knocking on your door about that. And Commissioner Sullivan, thank you again for talking more about the importance of the peer support and listening to peers, listening to young people and the Youth Advisory Board, and listening to parents and the Family Advisory Board. So thank you, all three of you, for your comments. And I know not only the panel, the ambassadors that are here asking questions, but everyone that's listening really appreciates your commitments. So I'm going to introduce
Can I just say
Kadisha.
one thing?
Sure, of course.
To add, because you just mentioned it, and it's something I forgot to mention, and that is particularly around the issue of staffing, retaining staff, encouraging people to go into the fields of behavioral health, is that we're going to be doing a hearing this fall. A joint hearing with myself, the Mental Health Committee, the Alcohol and Substance Committee, and the Health Committee. And so I don't have a date yet, so I can't tell you when that is. And I'm sure the commissioners will be finding out, and we'll be talking with them around their availability, because clearly they're going to be a very important part of that as well. And I hope that you will as well. Thank you.
Wonderful. Thank you so much. Kadisha, can I just introduce you and have you then take the reins in terms of introducing the ambassadors?
Yeah.
Go ahead.
Thank you, Paige. And thank you again to Commissioner Cunningham and Commissioner Sullivan and Assemblymember Joanne Simon for your introductions. We really appreciate you setting the stage for this conversation and taking the time to introduce yourself. So I'll go ahead and get right into it with our ambassadors. Our first one today is Samra Kelly. And Samra, I'll give you the floor to introduce yourself and ask your question.
Good morning. My name is Samra Kelly. I reside in New York City. I am the parent of a 17-year-old son who was diagnosed with substance-induced psychosis. Our journey through the mental health system has been one of the most challenging and eye-opening experiences of my life. At first, I struggled to understand what was happening. Was it just adolescence? Was it trauma, mental illness, or was it something else? Eventually, after a series of crises, hospital stays, a few residential stays, we received a diagnosis, induced psychosis. Hearing those words was heartbreaking, but also clarifying. It gave us a starting point, but navigating the system after that wasn't easy. The system felt fragmented, with mental health, addiction services, and school support often disconnected from each other. I found myself repeating our story over and over to providers while still trying to hold my family together emotionally. I'm here today because I'm here today not because I have all the answers, but I do have questions. Many families like mine, regardless of whether substances or mental health are the primary challenge, feel overwhelmed and isolated when our children are in crisis. What resources do you provide for families navigating both of your systems, including crisis planning and education? Do OMH and OASAS plan on increasing caregivers' direct access to guidance to family peer support services so that we don't have to navigate them? Thank you.
I'll go ahead and start, and certainly Commissioner Sullivan can follow. So the issue about the fragmented systems is something that is not new. This is something we've definitely heard about, and we're doing a lot of work to try and make that better. So we work very, very closely together, OASAS and OMH, to really think about how we can make the systems work better for people who have either or both mental health and substance use disorders. And so some examples of that include our certified community behavioral health clinics, the CCBHCs, of which we're tripling the number of those across the state. So that's in process right now. And that's, a really a tremendous number, especially when you look at what's happening in other states. And then another example of this is the crisis stabilization centers. And so this is another really big initiative where these are programs that are open 24/7 for substance use and or mental health crises, and they're staffed with that expertise so that people don't have to go into emergency rooms where that's really not their goal and they don't have the expertise for that. So we were investing many millions of dollars in this, and some of the programs are up and running, and many of them will be opening soon. We also have been working hard on our licensing process so that the existing clinics right now we can make it easier for them to be able to provide services for both mental health and substance use. And so that's work that we've been doing for some time. And we anticipate that those new regulations around the sort of different levels of care based on the need for substance use and mental health will be sort of made available soon. So we are doing a lot of work to try and get our systems to work more closely together, and so that you don't have to experience what you described, right? Of this repeated, telling the story repeatedly, et cetera. Then in terms of just some of the support that we have specifically at OASAS includes, we have a family support navigator exactly to try and help families navigate through the systems and all the systems. And so, those are individuals that have lived experience with their families. And so they're there to really support families going through this. And then other, ways include our recovery centers and our youth clubhouses. And those are other areas that they're not clinical, but they're there for the support. So it's where people come together, right, who have lived experience, who can, it's a safe space where there's groups, and there's just sort of dropping in and just to say like, hey, this is what's going on and what are the resources that are available in my community, and I just need help sort of navigating this. We've actually in the last year or two have substantially increased the dollar support for all of our recovery centers. And so we've heard across the state, that's allowed people to increase their staff, that, to buy a building to be, or a home to be able to have this, to expand their space, to expand their services, to have satellite spaces. So this is another area where it's really focused on supporting people, families, individuals who've been impacted in a variety of ways, and to really learn about the kinds of resources that are available in the community. So let me turn it over to Commissioner Sullivan, but those are just some things off of the top of my head in which we're really working to try and have our systems do better and to be able to provide additional support to families and individuals.
Yeah, thanks so much, Chinazo. And really, a lot of what I'm going to say, I'm not going to go repeat, but the connection between the key services, it's been a struggle in some ways. And it's not unique. Let me just say it's not unique to New York. This is a struggle nationally to really integrate services. And I think that we're really doing well in certain places we're still struggling. So the key things with the CCBHCs, the Community Certified Community Behavioral Health Centers, and the crisis stabilization that Chinazo talked about are really the newer programs that we're putting up. And in those, we are embedding the integrated care. So whatever we're now, what I'm trying to emphasize, anything we are now financing, we're embedding that. And you embed it by making sure that people are trained, that they understand how to work with individuals who have complex issues and have mental health and substance use issues. So it's a combination of designing the services so the right people are hired, and then also making sure that they're accountable for making sure that the care is truly integrated. The other areas where we're also working on integrating the care is in our mobile crisis system. We have a pretty robust mobile crisis system, which again wasn't quite as good at kind of responding to people with multiple problems. That we're working a lot of education. Mobile crisis teams are now becoming better skilled at doing really good kind of integrated care. And then there's our hospitals too. We have outreach teams now in the hospitals that are working with the hospitals, especially the acute care hospitals in the community, to make sure that they really consider the whole person when they come into the hospital or the emergency room, and that we don't segregate things off. And I think that those teams are there, and in our new guidance and regulations that we put into the hospitals where we're working with them, it includes the focus of integrated care. So again, moving forward, the other area I think we have to pay attention to is, and we're beginning to start talking with the educational institutions, because one of the problems is the way we educate people also silos people off. If you look at social work schools and you look at some of the programs, so people take special expertise, and then when they kind of graduate, they expect that that's what they'll be doing, and they don't really integrate. So the education part, both from training, but also when people come to us and educating people to really be able to provide the kind of integrated care that you're talking about. So I think there's lots of places and pieces that we're putting together. In all these new programs too, we have peer advocates, and we have peer specialists and family specialists. And we've had some trouble recruiting enough family and youth advocates. So we've done some dollars out there to help agencies try to help us train and get people involved, because we want more and more people. We have to invest in that. We have to invest in career ladders for that. We have to invest in all kinds of things to grow the peer specialist and the family specialist workforce. When Assemblywoman Simon was talking about workforce, this is a key area that we've got to figure out and continue to grow, because it's so important that those individuals are embedded into what we do. And again, we're trying to do that with everything new, but we also have to set up a career ladder and a career specialist, which we're working on. And also just to keep in mind that the general training that we do, we have tons of trainings on integrated care, et cetera, to bring the workforce up, so that kind of silo that you talk about doesn't exist. So we're hopeful, but we're not entirely there yet. So I know we still have people coming to us saying, do better at this, and we're continuing to work at it. And your advice and your suggestions about how to do better are really welcome.
Thank you. I can really appreciate like the trainings, I think, for the staff, and I think for myself, when my son was first admitted into these facilities, this was his first time, right? So this was his first time going into these facilities, and I could remember him like just coming back to me, letting me know like how staff perceived him, right? So that's that stigma of mental health, and just this is a kid that this is his first time, like he doesn't know what's going on. So I can appreciate the training of like compassion and empathy, because he's gonna go crazy on these staffs. Reality is like, this is my child, this is my baby. This is just your job. I don't care what he's in here for. At the end of the day, he's still my child. We still treat him with compassion and empathy. So I can appreciate the training. Thank you.
Thank you. Thank you.
I just want to say a word about stigma. So thank you for bringing that up, Shamara. Stigma is a huge issue. And honestly, I think it's the number one barrier in the field of addiction. It is, it's gotten a little bit better, but it's still really, really a big issue, and it impacts everybody. It stops people from seeking services. It keeps people from staying in services. it, keeps, it keeps everything hidden, and, and there's shame and all of this stuff. And it's a really big problem. We know these are medical conditions, and just like everything else. And so I think for us, this has been an area that we really have been focusing on, and how to reduce stigma. So some of that is trainings with the providers. Some of that is the language we use. I hope you've seen some of our public service announcements that are out that talk about stigma, and, really trying to get the word out there about, this is a medical condition. There is treatment. It is effective. This is like everything else. We shouldn't be judging each other. And, and there are services and treatment that exist. So we take this very seriously, the stigma piece, and really are doing a lot of work to try and address this.
Thank you, Commissioner Cunningham, Commissioner Sullivan, and also Samra, of course. I want to give a moment to Assemblymember Simon in case there's any response that she might want to add before we move forward.
Well, I think the only thing that I can add here is the fact that I think from the legislators' point of view, many of us are very aware of those concerns. We have children, we have family members. I know that the Department of Education, for example, has in the K-12 department, state education department, has really started to focus on mental health as well. I think it's a reaction to the trauma caused by COVID, but also a recognition that this has been an issue all along. It's just becoming a greater one. The issues of isolation, loneliness, children not knowing how to deal, parents not knowing how to help their children, teachers not knowing how to navigate. We often ask teachers to do many things they're not trained to do. So I think some of the issues about integrating of higher education training so that social workers understand more about a related field and vice versa. I come out of special ed. I was a teacher of the deaf. Nobody has a clue about hearing loss. I work a lot with young people with dyslexia, and most teachers aren't taught anything about it. And we're working very hard now with the new state action plan to change that picture so that the regular classroom teacher will understand more about the kind of difficulties that child is experiencing. And I think that model is very much the same for behavioral health. So I really appreciate the work that the departments are doing. And I know the legislature wants to help be a good partner in that.
Thank you, Assemblywoman. Okay, moving forward, I'm sure a lot of you know me as Khadija Abdulaziz, the Youth Policy Coordinator for Families Together in New York State, but today I'm also here as an ambassador and a self-advocate, so I want to step into that role for a moment and ask my question. As someone who lived through childhood in a household impacted by substance abuse and whose mental health struggles went unrecognized until adulthood, I'm interested in what supports are in place now for children of parents with substance use disorder in New York State. What early intervention programs, mental health screenings, peer support, or family counseling services does OASAS provide specifically for minors, and how accessible are they? What gaps has OASAS identified that it plans to address in upcoming years to ensure youth in such situations receive the support they need as soon as possible, rather than having to wait years like I did? Thank you.
Thanks, Khadija. I think so many things that we're trying to do to really support children of people who have parents who have substance use disorders. So, to start with, I would say is the work that we're doing in the school. And so we're doing that again with OMH as well in their school-based clinics and working together to do, to both provide the mental health services and then to sort of screen for and, work on prevention for substance use issues as well. In addition, we're in about 25% of schools in New York State where we have programs that are really focused from early intervention, pre-K all the way through 12. A lot of it is about resiliency and coping skills and really just reaching children throughout their entire childhood and reinforcing these, their evidence-based programs that are really focused on providing education and really building up skills in terms of resilience and coping skills. We also have youth clubhouses, as I mentioned before, and recovery centers. And so those youth clubhouses are, specifically for young people to be able to provide the support and the safe space to have discussions about what they're going through and what's going on in their families. And then, part of that is partnering with, family support navigators and in peer advocates who also, again, have lived experience and can help people sort of navigate what they're going through. I think in terms of the gaps that you asked about, so stigma, as I mentioned, is a big issue that we're really trying to address. Making sure that our services are culturally responsive, and so that is, we're thinking about how for kids under 18, that's different than young adults who are, from kind of 18 to 25. That's also very specific for the LGBTQ population, and really thinking about what are the special needs and making sure that we're providing the training and have the expertise in our programs to address those specific needs. And so we have designated programs that have that expertise, and then so that New Yorkers can know, oh, that's a program that definitely, is specific for young people, between the ages of 15 and 18 or between 18 and 25, that kind of thing. So, so it's really a range depending on what the needs are in terms of, the prevention needs versus the treatment needs, or more of the non-clinical sort of supportive needs that we have in these clubhouses.
Thank you for that, Commissioner Cunningham. And I really appreciate that you touched on non-clinical needs as well as like those gaps and those areas of support for people in particular circumstances. Another follow-up question I had that just came up as you were answering my initial question is, when you talk about those gaps of service and reaching people outside of maybe like the general areas where they would receive support. So for me, I was homeschooled. I really like that you touched on the importance of getting into the classrooms and the school district setting, but also there are students and there are people who don't have access to those areas. I also grew up in a Muslim household, and I think sometimes interfaith outreach is overlooked. So I was wondering if there's anything you could say to that.
That's a great point. That's actually exactly an area we're looking into right now, and we've started doing work in that. So I totally appreciate that comment. I think, and this again is part of the stigma work, because we know that faith-based organizations are really important in communities, and can reach people that we wouldn't ordinarily reach through the more traditional ways. And so I personally just like a month ago worked with an organization that is working with faith-based organizations around the country, going and providing the training, the language, the stigma, just and understanding what the services are. And so that is work that we're doing, and we're really looking on how we can expand that work across the state. So I'm really glad you brought that up, because that is something that we are actively working on, and we think is a really important part of the community that hasn't necessarily been included in these conversations. But it's such an important resource in communities and should be part of that conversation.
Thank you very much for that. I really appreciate you touching on that, especially language barriers, because I know we've had a lot of people come to us and have questions about that as well. So when we think about barriers, we want to think about all of them, not the ones that are just brought up the most. So thank you for that. Okay, we'll move forward now. Our next ambassador is Megan Rose. I'll give you the chance to introduce yourself and ask your question.
Thank you for being here and having me. My name is Megan Rose. I'm the Vice President of the NAMI Finger Lakes organization. I have been trained in do stigma work in high schools. I've founded and co-facilitate caregivers of psychosis support groups that we do online. I'm a certified family peer advisor, but most of all, I'm the parent of a child with a schizophrenia spectrum disorder. My question is, when a young person is about to be discharged from a psychiatric unit and there is evidence to suspect that they will not be following through with their treatment plan, how do you ensure they get the services and medications they need in order to function safely and productively in their community and avoid repeat hospitalization?
Hi, thank you. Thank you so much for the question. And it's a complicated answer. So I wish I could have it a bit more simple, but I think where our hospital, first of all, so you understand that we now have critical time intervention teams and a hospital connects program that's working on site in all the hospitals that have inpatient psychiatric units. So we now have an ability to go into those hospitals and see really what their processes are in terms of how they actually connect with families, how they connect with individuals on the units. The key thing here is engagement of the youth, engagement of the family. Often inpatient hospitalizations are kind of brief, and they don't really emphasize the importance of really making those connections with the individual who's there. So I'm not saying you can always be successful, but I think we have to be better at being successful with working with families and with the individual who's in the hospital in terms of what do they really want out of life? What are their we have a unit that we began at the state hospital working with the unsheltered homeless, individuals who sometimes, most of whom have a schizophrenia diagnosis, who have been on the street for years. And how do you get someone like that engaged in being willing to work with you? They're the individuals who usually say, go away, I don't want to talk to you. What we did was we began with working on what are their real goals for life, not what are your symptoms, do you take your medicine every day? What are you doing, but what do you want out of life? And when you can kind of do that, when you can have that kind of skill of engaging people, then, you can get to the other issues as well. So so what I'm trying to say here is it's a little bit of a different therapeutic approach that I think we have to use with individuals who maybe are not quite willing to see the challenges they face, but also the opportunities that they have in life and working with families. So that's one thing we have to do. The other thing is keeping the engagement going after discharge. It's not whatever happens in the inpatient unit is a brief point in time. And we need to have, for someone who maybe is struggling with making a decision about whether or not they want to continue in treatment or not, we need to have the outreach and engagement continue post-discharge, working with the individual, working with the family. And that's why we're working on these critical time intervention teams that will work with individuals at high risk and follow them and stay with them. These teams will go into the home, will go into the community with someone and work with them. And those are the things that we're putting up for discharge. Both, they will be working with individuals both from the emergency room and from the inpatient units. So following individuals and working and trying to engage, because sometimes it takes time and effort and really being there for someone through the series of problems that they may be facing to really get them to engage. Now for adults who have a significant history of hospitalizations or sometimes threats of violence, there is assisted outpatient treatment, which is a court-ordered phenomenon. And that's something that it can be very successful in helping individuals. It's not the first thing you want to do. You want to do all that engagement things I'm talking about. But if someone really can't for an adult, then assisted outpatient treatment can be asked for by anybody. Family members, friends, anyone can say. And then what you do is come up with a robust treatment plan and then go to a judge and say to the judge, what do you think? Should we say that this person really kind of has to follow the treatment plan, even though they're being resisted? AOT has been very successful in decreasing hospitalizations, decreasing homelessness, decreasing return to, and has gotten a little bit of a bad rep as, being something that is forced. It's really, I think, just another tool to help individuals who are really struggling to, maybe help make sure they get the services they need, but also understand just how important it is. Because when a judge tells you, you got to do this, it has a different flavor. Now, in the last year's budget, the governor also gave us dollars to not just do the court order, but for individuals who are having that much, to have voluntary enhanced services. So in other words, when someone comes now for AOT, what we're going to be working with the counties to do is say, okay, the AOT is a possibility, but what about a voluntary a voluntary involvement with all these services. And so we're going to have the ability to expand that. So we're hopeful that we'll still always have AOT, but maybe we can have a little bit of a scale of balance that will also engage people with lots of wraparound services. I think the other thing that the system just has to be is flexible. Know that mental illnesses can be a relapsing illness too, and people can sometimes, our medicines are hard to take. We have to work with the family, we have to work with, and we need to be there for someone through one crisis after the other, and to whatever extent we can be, and hopefully help them join. So I don't know if that's been helpful, but we are really trying to move the system to that kind of continuity to make sure that someone gets the help they need. But then if as an adult, you really can't, with all of that effort, then there is assisted outpatient treatment.
I'm so glad you mentioned AOTs. It's been very successful in my family. It's culturally sometimes very hard to have a psychiatrist do the work that would put it in place. And that was the case for 2.5 years for us and 3 more hospitalizations. And we're waiting this week to hear about another AOT being put in place, and we're hopeful. My loved one is 24, so an adult. And the hospital where they got their service refused to start an AOT process in hospital. So I know, I see your face.
No, we need to, let me say, that's totally and completely unacceptable. So if you get to us, I mean, we will work with that hospital. They can't do that.
Well, they've only ever done it once.
Okay, but they shouldn't do that.
No, they shouldn't. So I had to talk to our local commissioner and talk to our mental health department. And fortunately, we have a good relationship there, and they worked with a hospital to coordinate once our loved one was discharged that they'd been served a letter in the hospital. That's all the hospital was willing to do. For the AOT to start being taken place. So we had to cross our fingers and hope our loved one made their appointment. And they did, but it's been a hellscape. So
I would like you to just, how long ago was that? I mean, I don't mean to, was this recent?
Oh yeah, 8 weeks ago.
Do me a favor, you don't have to say it publicly here, but would you email me
Yes.
the hospital?
Yes, I will.
Because that's not appropriate. Now,
Right.
I understand sometimes the hospitals feel it's a lot of work and they have the time for the psychiatrist, but no. And if they're having that kind of problem, then we can work with them and get them the help to do it. But I'm so glad that your loved one went to the appointment, but I agree with you that for many people, that's not likely to happen if you don't do the order in the hospital. So please let me know, just email me.
Thank you, I will. I had a follow-up question, but I got all excited about the AOT stuff.
Okay, thank you.
What support can caregivers and families access to help navigate these circumstances? I sort of feel like you already answered that question. And I want to raise one more thing with you, which is I'm a family peer advocate certified, but I can't bill Medicaid for somebody who's over 18. They don't certify older youth to be serviced and bill Medicaid. So that's yet another issue.
Yeah, well, we'll work on that one. We'll work on fixing that. But the other thing is, I think we're going to be really alerting the hospital. It's amazing how the hospitals are not even aware of the kinds of things that NAMI does and the availability of your supports in the community. I mean, it's just, when our guys go in and talk about it, they go, oh, no, that's not it. So we really need to work, and we're working with the hospitals to connect. I mean, one of the biggest, as we all know, of preventing rehospitalizations is getting those community supports working with individuals. So that's something we're going to be pushing. So we're probably going to be pushing more business to NAMI across the state, because really it really should be an integral part of the way the hospitals work and the way they think about discharging someone and connecting with those supports and with the family advocate. So we're working on that.
Right.
And we've got the billing for these services, it's still a struggle, but we keep fighting to get it in whatever way we can. And we'll keep working on getting these services so that they can be paid for at the rate they should be paid for and as easily as they should be paid.
Thank you.
Thank you. Thank you.
Felicia, do you want to introduce the next?
Yes, I was just giving you a moment. I saw you came off mute.
Oh, yeah, I was just going to say thank you to the commissioner for recognizing that, and that there needs to be revisions to how the family peer support and youth peer support is able to be accessed by people over the age of 18, families who have kids over the age of 18. We look forward to working with you on it.
Thank you for that. Thank you, Commissioner, and thank you, Megan. Move forward now to Valerie Haynes. Valerie, I'll give you the chance to introduce yourself and ask your question.
Thank you. Can y'all hear me okay? I'm at work, so that's why I'm off camera, but thank you for the opportunity to speak with y'all today. My name is Valerie Haynes. I'm originally from New York City, but I live in Rochester now. And I've been navigating this this mental health system since my daughter was 18. She's now 30 years old. And so some of the things that Commissioner Anne spoke about, and also Commissioner Joanne Simon spoke about, really resonated with me because of the fact that, you know, her first mental health crisis, she was already 19 years old. So she was already over the age of 18. So my ability to advocate for her was highly challenging. And so it was a strong push. So we relocated to Rochester, and my question is really speaking about my experience versus what's actually happening now. So my experience is mostly about the challenge of dealing with providers in the hospitals when you have a child who's an adult, but she's still living in your home and you're her caregiver. So I think that some of the commissioners already spoke to that. And so my question is the concrete steps that OMH is taking to make sure that caregivers are not sidelined when dealing with, you know, their child who's over 18, obviously she's 30. So that, for example, since she's been dealing with this since 19 years old, I'm very aware of when she's about to have a crisis. And her crisis begins when she refuses to take her medicine. So that if she refuses to take her medicine, then the only way that she's going to get help is if she's admitted to the hospital. So for me, I can't do that because if there's no, I mean, based on my experiences, if there's no threat to herself or threat to the family, you know, the providers are not really open to that. And I'm talking about open to my engagement and involvement. So it becomes a matter of not preventive care, but after the fact. So if I'm not able to prevent her crises and she's going into a full-blown crisis, then that changes my ability to advocate for her because she's now in a crisis. So providers are shutting me out. So my question is what steps are y'all taking to prevent things like this from happening? Y'all talk about you know, the providers having to, needing to include the family, but that's not really happening in my experience. So if it's if it's based on the provider as opposed to a policy, then that's really difficult to navigate. So I guess my question is you know, what steps are being taken to make sure that families and caregivers aren't sidelined when the children are 30 years old, but still living in the home of the caregivers. Thank you.
No, thank you for that question. And you know, caregivers should never be sidelined. But it happens. I know it happens. The guidelines, just in the last year or two, we put in regulations which require, I'm talking about hospitals now specifically, hospitals to engage with someone's support system. And if that support system is a family, or if that support system is a friend, or it's someone else, that they have to engage with them, they have to have them be part of what is going on now. There's two things that are tricky here. And one is when you're an adult, your ability to sometimes refuse to have the family member involved. That never precludes the hospital from getting all the information from a family member, from someone being able to explain what's going on. All that can be given if the person is actually, if for whatever reason at that point in time, the person client in the hospital is refusing, that doesn't preclude them from getting all the information they can from everybody, and then working intensely with that individual to understand what their issues are. And if you work really hard, often being able to get that person to be able to, as they get a little bit better, to pull in the family and work with the family. And often you can get that consent. I don't think we work hard enough at that. So let me just say that. I think there are ways to do that, and we have to do that better. So that's first and foremost. But secondly is then how do you engage with the family on an ongoing basis long term? And there again, we sometimes fall short. You know, a family member, and I agree with you, a family member knows when someone is having trouble, and you know the pattern, and you know what's going on. The recent changes to the commitment law give more leeway for individuals, physicians, to make the decision to admit someone. For example, when a family member says, I know this is the pattern, I know that this person, you know, my loved one within a few weeks is going to really be in very bad straits, please help me with this. There was always some case law that supported that, but the actual writing of the law said it had to be acutely dangerous to self or others. So the addition to the involuntary commitment law now talks to someone who is not able to understand the need for shelter, taking care of themselves, medical help, which includes mental health help. So I would hope, we're going to be working very hard with the hospitals to understand that there's more leeway now in that involuntary commitment law. You have to use it very carefully. You never want to sacrifice someone's rights, but there is a little more leeway there now. And it's going to take a while to get this into the culture of the hospitals, to be able to admit someone who really needs that help based on what you're hearing from neighbors, family members, the police who brought someone in perhaps. So there's a little more leeway, and I think that will help, let me put it that way. But engagement is another critical thing. And I just as I said before, so we should be working with the families when someone leaves. We should have things like we have advanced directives. And when your loved one is doing well, we want that person to fill out an advanced directive. An advanced directive says that if I'm not able to, because I've gotten a relapse, this is what I think should happen. And I don't know if your loved one has an advanced directive, but that's very helpful, because then that's right there, right. And we can put those into something we have called psyches, which then is available to any emergency room across the state where someone comes in, and they can look in the computer under that name. You do this all with consent, and they can see, you know, on an emergency basis, they can go in and look. So advanced directives are another thing which we have to use more and more. So people, when someone is well, they say, you know, when I'm not well, this is what I want. You can even say what hospital you want to go to. You can say what medicine works for you when you know you're getting better. You can put all that in an advanced directive, and also say very clearly that this is what I want. And then you can say, you know, my daughter has an advanced directive. Please go into that, look at it, look at what she or he wants, and you know, we can do it. So that can help. Some of the changes in the law, I think, will help. And then working with the hospitals so that there's a real connection with that family member when someone's better and they leave, that you've really got to kind of have that and really be available to hear. You can always hear. People say, oh, hippie, you can't talk. It's not true. I mean, maybe they can't reveal certain things to you, but you can say anything you want, and the doctor should pick up the phone and listen and hear what you have to say. So there are things that we're doing that I think can make it more effective, because yes, sometimes when people are in the midst of a crisis like that, they have trouble realizing they need help. So those are some of the things that are in place. And then also and I mean this, if any, and you should say this to all the advocates, if a family's ever really feeling that they're not getting a response from our system, then you call our field offices. Believe me, we get calls like this all the time, and we work very hard with the hospital. We say, no, wait a minute. You know, have you talked to that family member? Really talk to them? Do you know what's going on here? And so we can intervene when the system isn't doing what it's supposed to do. And nobody should ever feel like they can't do that. You should call us and say, because that's what we're there for, to kind of help intervene when things aren't going as well as they should. And believe me, we get calls and we handle it. So to get that word out as well.
Thank you so much, Commissioner, Anne Marie. And I have a follow-up question, because, as I mentioned, right now the situation has shifted where her last mental health crisis, she became estranged from the family, so she's kind of like on her own. Like, and there's no real communication because, it became like she felt like I was trying to control her, so like my ability to help her has now been prevented because of this thing. So I know that in terms of me advocating for her, I'm gonna reach out, like you said, to the OMH for some questions I have, but just on this other note, like how can she advocate for herself? Like like Megan mentioned, there's no AOT where she is. So how does she get access to these type of assistance at 30 years old as an adult? She's pretty much homeless. So that um so how can what like how can she get in touch with assisted outpatient treatment? Like how does that work? She didn't get it from the hospital when she was discharged. So which caused her to go back and forth, back and forth, back and forth. So that's where we are now.
Yeah,
So
that's, yeah, again, she can certainly call, certainly our field offices can connect, and all the counties, any county DCS, the counties are responsible for the AOT in each individual county. So you can go to the county DCS, the county mental health person or DCS, they all know about AOT, and there's a number that you can call. And you can also just call our field offices, any of our field offices, and say, how do I connect? They all have AOT coordinators in the field office that can help with connecting someone, to those services. So anybody can always just contact us and we'll make sure that they get the AOT or any other service that they're having trouble accessing. And the counties are also very helpful with this single point of entry, the SPOAs, in terms of ensuring the kind of wraparound services that someone may need. So if she's having trouble, and the other thing is if she's homeless now, and you could call our safe, I don't know if you know where she is, but you could call our safe options support teams, which are our homeless outreach teams, and just say, my daughter's right now, wherever she is, could you go and talk to her? They'll do that, so they can also make the connection, for you. They might not be able to tell you what that connection is if she doesn't want them to, but you can refer her to that, and they can go out and talk with her and see what she needs.
okay, thank you. I appreciate you so much. And thank you too, Megan. I'll definitely reach out to you.
Thank you, Commissioner Sullivan. It is so important to keep families informed and engaged, and also it's very important to keep community members aware of the opportunities for self-advocacy. I want to move on to Cody Hopman and give him the chance to introduce himself and ask his question. You're on mute. Oh, there we go.
Sorry. Sorry. My name's Cody Houtman, and I live on Long Island. As a young person growing up, I struggled with mental health challenges early on. Sometimes I didn't want to be here anymore. Over the years, I was hospitalized more than 20 times, was handcuffed and taken in the back of a police car to the nearest psych emergency room. Several times, all this while my mother fought endlessly to get me the services I needed. However, I just sat on wait lists. Over time, I started seeing things differently. I got involved in advocacy and learned more about the mental health system and realized that there was nothing wrong with needing help. The real problem was that there was a hole in the system with state responsibility that was failing kids like me. For some reason, the care was there on paper, but not in reality. I lost the hope that I would never get the care I needed, but I never lost hope for the generation of kids that wouldn't have to go through what I did. Today, I feel a lot of hope, not for me, but for future generations. I feel this way because recently the state settled a lawsuit that will redesign the mental health system for many of young people across New York State. So now that there's a legal system in place, I would like to know what the state will be doing to implement a better system for kids like me and how youth voices can continue to help shape the system for future generations.
Yeah, thank you very much. Yes, we do have, we have signed the preliminary agreement on the settlement, so, which is great. And I think it's a very comprehensive settlement agreement. It will have about a year or more of real planning that's going to go on with a lot of stakeholder input, including from youth, from families, et cetera, as to what the service system should look like. And so we have to begin with that. And I think, you know, our plans, we have ideas. And I mentioned a number, for example, of some of the crisis services and things that we have. But this plan is coming together to look at the whole system, get lots of input from everyone. And then within that year and a half, the planning, if the settlement is, you know, it's up for public comment now, it's out there, it's on the website. Then we begin the implementation process, and the implementation process will probably take couple of years after that. In the meantime, though, we're going to be putting up some things as we get input and as we grow the current services that we have. The lawsuit, and you know, I wish we didn't have to have a lawsuit, but the lawsuit actually pushes us to do a whole comprehensive review and to talk about the things that everybody's been talking about here, a little bit about how there's gaps in the system, things that fall between the cracks, ways that the coordination doesn't happen, even though we would like it to be happening, but it's not. And to do that in a comprehensive way that will have a real impact, as you said, on future generations, so that some of what you experienced, hopefully other youth will not have to experience, and they will get the help they need in a much more coordinated way. So we're very excited actually about what this can offer us. And there's an out-of-state consultant who's done some of this work, who's also going to be with us, helping us to think differently about what we're doing, and then tremendous stakeholder input from everyone in New York, including lots of youth input, family input, everything, so that we can really develop an exciting system here in New York. So actually, I think it's putting us on a good path. It'll take time, but I think it's worth the effort and the planning to make sure that what we do this time really works. So I think it's exciting. We're going to go forward.
Thank you.
I want to give the Assembly member and other commissioner a chance to also answer, but I just want to say thank you, Commissioner. That was a really transparent and wonderful response. We really appreciate that kind of approach, that that you see it as an opportunity. We do too, and we look forward to working with you on it.
Yeah, it definitely is. Thanks.
I don't have that much more to add, besides for, you know, I do think this is also something that we're looking at in terms of how to better incorporate the voice of young people into sort of constantly trying to improve our system. I think that's, you know, there's steps that have been done in the Office of Mental Health that we're looking at to think like, oh, is that something that we can also replicate? You know, so I think that we're certainly paying attention, and we obviously know that, you know, there's a lot of work that we're trying to do to make sure that we're supporting young people. And also, you know, for us, at least, it feels a little different, what's been happening recently with young people and substance use. So for example, substance use is actually going down in terms of the use across the country and across the state. And I think people don't realize that there's an assumption that like use is going up, but that's actually not the case. And this has been going on for the last 10, 15 years. Actually, less young people are drinking alcohol, less young people are using substances, but people are still at risk for dying of overdose. And so there's a little bit of a shift happening, and I don't think that anybody fully understands this, but obviously we have the internet, we have social media, there's, you know, pills and counterfeit pills. And so people experiment. And I think that experimentation is more deadly than ever before because of the drug use, but it's not that people necessarily have addiction. So we're trying to also just understand, you know, things are constantly changing. obviously, right around us. And we're really trying, and I think it's changing more for young people, especially with social media. And so we're trying to get a handle on, like, really trying to understand what's happening so that we can make sure that we're, again, in the right position to support that and address those needs as they're evolving. So, and I do think that having the voice of young people, like, right there at the table to help us understand that is really important. So that's just a, like, we have our eyes on this, and we're really doing a lot of thinking about how things are changing, and so then how we need to change to address those needs. And again, it's constantly changing for everybody, but I feel like it's changing even more for young people than the rest of the population. So again, looking at kind of how OMH is addressing this and their, advisory committees and stuff like that, and thinking about how we can do something similar at OASAS.
Thank you, Commissioner Cunningham. I just want to give a moment to Assemblywoman Simon, if you'd like to jump in.
Yeah, all I can say is, we're learning from you, what is working, what's not. We're learning from, the agencies when they're putting into effect new programs. The legislature is always looking to see what's working, what isn't. How can we improve that? How can we work with the agency to improve those services? So that, our role is legislation and the budget, right, and funding. So, for example, we have very little role in the passage of regulations. That's a different process through the agencies, although we like to know about regulations when they're proposed, and to have a sense so we can encourage people to comment on those regulations. That is part of the process of making sure that the regulations that are in fact enacted are the right regulations that are addressing the needs that people have and have been tweaked so that they're going to be more effective. So our role is much somewhat removed from the day-to-day of people's lives. So for me as a legislator, finding out more about what it is that's working and what isn't, and working with the agencies about the programs that they're putting into effect, so that we are aware of what it is that we need to be engaged in terms of monitoring and listening to our constituents. So I encourage people, if you have issues, to bring it to your local legislator, to your state assembly person, your state senator. Not everybody is involved with mental health. Not everybody's on the committee, but that it doesn't matter, right? Because when we are talking about these issues, when we have hearings, lots of legislators participate in those hearings and want to know. And you'll see in the beginning of a hearing, if you watch, that lots and lots of people come to just observe and to listen to the commissioners and the agencies make their presentations. And that's very important information for most legislators. So I encourage you to engage your legislator, whether they're on a relevant committee or not, because you're going to need their help and we need their support as well.
Thank you, Assemblywoman. It is so important to stay engaged with your legislators, and thank you for sharing the legislative perspective. We just had Senator Brouk join us.
Great.
So I'll give them a moment before I jump into the next question.
Good morning, Senator Brouk. This is Paige. We just want to welcome you and give you an opportunity to say hello and introduce yourself. You're on mute if you are trying to. Here she is.
Hi. Sorry about that. I was getting situated. Nice to see you all.
Nice to see you. Thanks for joining us.
Yes, of course. Happy to. So, Paige, were you just saying I didn't quite get your audio? Just a quick intro? Is that what
Yes, please. We had the two commissioners who you all know very well, who
Yes,
are
I do.
here today from OMH and OASAS, and Assemblywoman Simon. And they've been answering questions. As you know, you've done this town hall many times with us. We're down to the last question, but we want to give you an opportunity to just introduce yourself and talk a little bit about stuff that's happening in the Senate and specifically in your committee that families and young people across the state would like to hear about.
Yeah, thank you. It's so nice to be with you. I think usually we do this earlier in the year or closer to session. So I'm actually grateful that it's happening now because I might miss it if it's in January.
That's why we changed it, because too much going on in January.
Yeah, exactly. And I do have to just say, Commissioner Sullivan and Cunningham, it's so nice to see both of you, especially Commissioner Sullivan. We see each other so much during those 6 months a year, and I bet you're really missing us just bothering you in Albany. And of course, my colleague here, Assemblymember Simon, so nice to see you. Love making good trouble with you. And so great to see all of the families together, folks. And I just want to say thank you so much for all of the work that you all do all year round. I am constantly in awe of just the rigor and energy and enthusiasm and conviction that you bring to this topic. It certainly energizes me as a legislator as well. So, from my perspective, I think, gosh, I do feel like we've done so much over the last few years when it comes to supporting families and children with mental health and substance use. But unfortunately, it just never feels like enough because there's still just so much more to be done. As I think about this year and going into next year, one thing I'm really excited about is a bill that we passed actually in a previous legislative session, the Student Lifeline Act, but that actually went into effect this year. And so it's, actually got some more attention now. And so that's the bill, for anyone who doesn't know, where it really came out of talking to high school and college students about kind of like what's stopping them from getting the care that they need. What more can we do infrastructure wise? And we kept hearing that having this information more accessible was a key piece. And so what the Student Lifeline Act did is put the 988 crisis lifeline actually on student ID cards for every college student in New York State. And I have to tell you, it was one of the most amazing things when someone earlier this month sent me a photo of their new student ID card, and on the back of it had the crisis lifeline on it. And it was one of those moments where, we write these bills, we work with the commissioners on like, how are we going to implement it? But really the reason we're doing it is so that student has it in their hands. And so I just think about how a lot of the things that we're doing, it's kind of the first time, right? And I do have to give credit to a lot of the leadership in Albany, from the governor to the legislature. There is a strong understanding of the importance of reforming our mental health system, right? And so a lot of these things are new. And so they feel, new and exciting, but we're going to see the effects of it in years to come, right? You don't destigmatize, searching for help in crisis by just putting it on a card. You do that by that happening year after year after year. Every time you swipe in on the back of it, you're seeing that number. You're talking about it with your friends, right? You're getting more comfortable seeking that care. And so, so that's one that I am so excited about. And it's been so wonderful to see that come to fruition. And I'm grateful to, OMH, obviously, and all of the partners that help these things and support all of these institutions to be able to do that. A couple other things I wanted to just point out, not to monopolize here, but the other thing I think is really, really important is continuing to center particularly families and youth voices in our legislative process. Personally, I do that through our Youth Mental Health Roundtable, our Youth Mental Health Advisory Board, which maybe someday we'll do statewide. We do have legislation so that the legislature actually has a statewide advisory board to help us come up with legislation in addition to a lot of the things that happen with the executive. And so that's something we're hopeful for. And then, I think we need to continue to grow our workforce. We tried hard last year with the Healthy Minds, Healthy Kids, and making sure that we were making nearly $200 million investment and cutting down on wait lists. And We got farther than we'd ever gotten before, which was very exciting. That's process, it's progress. But obviously we're going into a very difficult budget year. But my goal will continue to be to put these topics at the forefront and not at the forefront of the agenda and not the forefront of the chopping block, because there will be obviously very hard decisions being made over the next 6 months. But we have to protect the progress we've made, and we have to understand that we're barely scratching the surface. And I think, I wasn't here for all the questions, but I was able to see some of them and some of the experiences that you all personally shared. So it's very clear to us as leaders that there's so much more that needs to be done in addition to what we've done. So please know that we don't make a habit of patting ourselves on the back for the bits of progress we made. Rather, it's a fire under us to continue to push forward. So that will be the singular goal, to really protect that progress. And we need to continue building on those investments, right? We know that we get tenfold return on this investment by investing in individuals and families' mental health. So thank you.
Thank you so much. And I'm so glad that you had the opportunity to see the questions, so you knew some of the stuff that we've already talked about and you were able to respond to that in your remarks. I just wanted to let you know also that Commissioner Sullivan just responded to a question from Cody about coordination and the settlement. And she made a point that it's an opportunity for the state to reconstruct and revamp our children's behavioral health system, specifically around the community-based services and CFTSS. So I'm glad you're here for that, to learn about that. And Assemblymember Simon mentioned a hearing, but I don't know, Assemblywoman, were you talking about joint, or is it just Assembly in the fall?
It's an Assembly hearing.
Okay, specifically to talk about workforce and investment in workforce. So we look forward to attending that and participating. So Kadisha, we have one last question that we want. It was actually a panelist or a ambassador, a young person who at the last minute was unable to attend, but Kadisha is going to read her question for her.
Yeah, I'd still love to uplift her voice and make sure her question is asked, and she can always watch the recording and get the answers that she needs. So this question comes from a young person who had a crisis last year, and she said, "Last year, I went through a mental health crisis and called the hotline multiple times. Each time I was met with very general advice that didn't provide me with the concrete supports I really needed in the moment. Eventually, I unfortunately ended up in the emergency room where I was only given a pamphlet with telehealth information and no meaningful follow-up or resources. My experience left me feeling unseen and unsupported. Many others have shared similar stories of reaching out during a crisis but not receiving effective help. How can OMH ensure that when someone is in crisis, the resources available, whether through hotlines, crisis response teams, or emergency care, actually provide immediate, personalized, and effective support, rather than generic advice or pamphlet? What steps is OMH taking to strengthen crisis response so that people in need don't fall through the cracks and end up in unnecessary emergency room visits?"
Really, thank you for that. A 988 crisis line, overall, we have gotten really good feedback on the crisis line. That doesn't mean, in terms of individuals feeling they were helped, individuals feeling that they had time to talk, the average time on the crisis line is about 20 minutes. That means that some are much longer, some are shorter. But when someone doesn't get what they need, we really need to know. And we do some, what do you call it? That customer shopping thing where you blindly call. So we do that. We do have individuals call as a way to check quality with a price and see what kind of response they get. But if anybody calls those crisis lines and doesn't get what they think they need, then I know it's hard because you're in crisis, but after time, you've got to call us and let us know. And I would love to speak with her about what happened, and if she's willing, what happened, what didn't she get from the crisis line? The crisis line should be able to provide really concrete help and also follow up. They should be always offering, can I get back to you? Did it work? Didn't it work? Some people don't want that, and that's fine. But if someone does, we want to be able to get back. So they should be doing follow-up. They should have a whole referral system at their fingertips to help people get the help that they need. And then if they don't get it, follow up and say, well, what didn't happen? What didn't work? So if it's not working for someone, then we really do need to know, because 988 is something that we are really using as the entry point for a lot of people to come and get the help they need, and we're publicizing it, all over the place. The other issue of, well, okay, so supposing even 988 went well, but you still went to an emergency room. No one should be given just a pamphlet. Okay. I mentioned this before, but just to say again, what we are putting now into the hospital system are workers from OMH who are going to all the emergency rooms, all the places, and talking with those emergency rooms about what they should be doing on the new regulations that we have passed that require a more comprehensive plan for someone who comes in crisis. So basically, you shouldn't just call this number. They should facilitate you're getting an appointment to where you're going. Now, once in a while, maybe if you want to leave in the middle of the night, that won't work, but they should be facilitating you're getting where you're going. And there should be a follow-up that could happen. And it should never just be a pamphlet saying this is what you could use. So I'd really love to talk that we're working on this. Some hospital emergency rooms do a really great job with this, and quite frankly, some don't. So it's our responsibility to be in there working with those emergency rooms and making sure. And these new regulations, which we passed for the very reason that you're bringing up, that sometimes they haven't been doing the job that they should do. I mean, if you go in with a heart attack, if you go in and you have a cardiac problem, they don't just, send you out with a pamphlet. They do a kind of follow-up of what you need, and everything, it should be the same, whether it's a CPAP, one of ours or a regular emergency room, they should not be doing that. So we're going to be working with them to improve it. I just want you to know that that's a process. And if somebody, as I said before, doesn't get what they need, or the family feels they didn't get what they need, please call us and let us know, because that's how we get feedback back to the hospital. And we work to say specifically, this didn't work. But yes, we're going to get the hospitals to be better at this. And the governor's been full support on this in terms of the regulations that we passed, and the fact that we have now the staff to go in and find out what's actually happening in the emergency rooms to make sure that people get the services that they need. But please let us know. And 988, I really do want to know if there's anyone who's not getting what they need from 988. We do a lot of training for individuals. We try to do our quality controls. We talk to all our call centers all the time to make sure that they, so if it's not working, we need to make it better. We need to make it better.
Thank you, Commissioner Sullivan. Thank you for that answer. It was really well-rounded, and I love that you're offering so much engagement with OMH to everybody who has questions and needs extra support. It's really what people come here for, so we really appreciate that. I know you have to hop off at 12, so I just wanted to say thank you so much for joining us and for all of your answers. And then I'll just give the opportunity to Commissioner Cunningham and our legislative members if they would like to jump on and add anything here.
I would love to. And I also just, in the event that is this Cameron's question, right? In the event that Cameron does watch this, and I hope you do, I just want to say how deeply sorry I am that this was your experience. And also thank you for using it to share with us and really highlight where the holes are, because it is so true. The commissioner said, right, you pass laws, you're implementing policies, but at the end of the day, none of that matters if your experience is not what we intend it to be with all of these changes we're making. So I think it's really important that people continue to have the courage and bravery to share when things are not going well. I do want to share that, there are a few things that I think that we need to continue to build on to help avoid situations like this. One of those is, when we passed the 988 legislation here in New York State, one of the pieces of legislation that I introduced that was passed when the original $35 million was put in the budget for it was around particular training for 988 counselors, and especially for different marginalized groups, to make sure that counselors would not do more harm than good, because unfortunately we know that that is possible sometimes when there are cultural discrepancies. In addition to that, we also had reporting mechanisms that we sought to implement so that we could be aware of some of the metrics, right, and the quality of what these calls were doing. But I think more than any of that, what we see with 988 is that it is the first step in creating a crisis response system. Right? What we know is that by and large, over, I think it's like 98% of calls do not dispatch emergency responders to someone in crisis. But what if we had something like Daniel's Law in place so that it wouldn't be reliant on EMT or, you know, an ambulance, a fire, or a police officer going, but we actually had mental health responders, right, who are you know, core number of them are peers, social workers, crisis counselors. And so that changes our crisis system so that someone who is calling 988, it goes beyond general advice. And if you are someone who could use a trusted mental health, again, unarmed, you know, professionally trained mental health provider to show up to help you, you may ask for that if you knew that was an option. And so I do think it's important to point out that we have made huge strides in New York. And overall, I will say we have heard good experiences with 988, but that does not discount the ones that do not go well, because when they don't go well, it can be incredibly devastating. And so I think that we need to continue that full continuum of crisis care so that we build that trusted system, right? So that if you know someone trusted is going to show up and help you work through that, get you paired with treatment, right? I think that that's incredibly important. And then a couple other things I want to point out is, you know, Assemblymember Simon and I, gosh, we had countless, I think we were on the phone constantly during the budget process, you know, talking about some of these holes in our hospital system. And the fact that, you know, the commissioner touched on this, that there are significant gaps in service for individuals who are coming in with mental health needs. And you hear this from the psychiatrists in the hospitals, the NPs, you hear it from intake, you hear it from patients who are looking for care, that there is inconsistency throughout the state of the care that you're going to get when you show up with a mental health emergency. And oftentimes we are hearing that revolving door of not getting information that you need, not getting treatment you need. And so I do hope, you know, we fought for some change. I think we need to do more. But as the commissioner said, I know that they are, you know, rolling out some of these improved, stricter regulations, quite frankly, to ensure that this doesn't happen. And the final piece is more about prevention. So for the last, oh gosh, I think probably since I started, the last 3 or 4 years, I have been fighting to do what Colorado did when their students went back from COVID, and went back into school. They understood that they were going to be putting their students at a disadvantage. They had been isolated. There were probably increased mental health needs. And so they statewide funded 5 free, they had 6, I think, free appointments, mental health appointments, no questions asked. You filled out the form online. It's imatter.org if you want to check it out. You did not need insurance, and you could at least get these appointments, and you could do it tele or you could do it in person. You know, Colorado, Wild West. Sometimes you're not going to find, a therapist close to you. But that was the point, is that it was supposed to be accessible and free, regardless of insurance, to at least help you bridge a gap to get more sustained treatment. To be honest with you, I think a young person like Cameron, because I think it was a youth maybe, may have benefited from something like that if we had been able to get that funded here in New York State. And we have tried different pilot programs. We'll continue to fight for it. But those are the kinds of things that we try to put in place so that you don't feel like all you have is 988. Right? It's not one size fits all. We want all of these channels to work. So those are just a couple things that I hope give hope that we are continuing to work on. But also I appreciate the chance to take accountability, right, as a system when it's not serving people equally. Thank you.
Thank you for that, Senator. I can say, as a young person who struggled with mental health, that does give me a lot of hope. I didn't have access to anything like what you're talking about until I went to university, which was for me not until my junior year. So to hear that you're emphasizing accessibility and free access as well when people don't have Medicaid or insurance to cover mental health services is really important. I want to give a moment to Assemblywoman Simon now.
Thank you. That was a great presentation, Senator, and hit on a lot of the points at which the Senator and I have worked together and have spoken about. I did see a comment in the chat maybe about warm lines. That is something that, for example, in Brooklyn, I have helped fund warm line for the Brooklyn Center for Independence of the Disabled. And so that's disability focused, but of course that includes mental health as well. And, you know, that warm line is talking to somebody who can help you on the phone, doesn't necessarily end up being a referral, doesn't go to 988, but it's not a hotline, it's a warm line. It gives you some sort of lower level help that helps you over some of those humps that you might need before you end up in more of a crisis and are calling 988, right? So I think that the warm line idea is a really good one. It has been very successful, I know, here in Brooklyn with the community, and it's something that I'd like to see more communities be able to put into effect throughout New York State. And that's something that is available to anybody. So if you're a young person and you call, it's not like, doesn't matter that you're not 18 yet if you call a warm line, for example.
Thank you, Assemblywoman. I do think that the warm line is a part of creating comprehensive access to support, no matter what level of support it is that's needed. So I'm going to hand it over to Paige now, because that was our final question.
Thank you, Khadisha. I just wanted to reiterate the importance of these town halls and thank the panelists who attend, because this is an opportunity. We joked when we first started doing them that it's sort of like your own private opportunity to testimony. You know, the commissioners have to testify during the budget hearings, and this is a one-on-one with some questions specifically from families and young people. So it's really like, I think it's a benefit to the commissioners, it's a benefit to the legislators, and it's certainly a benefit to us as at Families Together and to our young people and families that we represent. The reason we changed it to the fall was so that we know that the commissioners are sending out their letters to the governor about what their budget needs are for next year. And instead of waiting till the budget comes out and then having to defend it, we're giving you the opportunity to proactively tell the governor what young people and family members say they need. And then, of course, the legislators are here to hear that, and then they'll recognize that when they're in their hearings and recognize it when they see the budget, that it reflects the stuff that we talked about today. So we're hopeful that that will help as you decide what priorities your agency needs to focus on. And we are hopeful too that the legislators will continue to work with you and with us to make sure that the issues that we talked about today and any other times that we come to you and to either state agencies or to the legislature to say, this is what families are saying, and this is what young people are saying. I know that we have friends in all four of you, and we're so appreciative of that. We appreciate the ability to call you, to meet with you, and to have this dialogue where our members get to see that you really are working for them. So thank you so much for joining us. And this one will be the second to the last, and our next and last town hall. All of these are being recorded and will be on our YouTube page, on our website, is the Juvenile Justice Town Hall, which is on Monday. So at 1 o'clock. So we look forward to having people join us for that. Everybody who's watching, please sign up to watch that one as well. Thanks again, commissioners and legislators. Take care.
Thank you all.
Thank you. Bye.
Thank you.